I have held a man down while another man cut into him. I have felt what that is, the specific sensation of a human body fighting with everything it has against what is being done to it. The sound a man makes when the sound goes beyond what sound can carry. I have done this, and I have gone home and eaten my supper and returned the following morning and done it again. I am telling you this at the beginning because I want you to understand what surgery was before you hear me talk about what surgery became, and because I think the distance between those two things is the most important distance in the history of medicine, and I was alive on both sides of it. My name is George Aldous Pemberton. I was born on the 11th of January, 1842, in Bristol, England, the son of a physician who was the son of a physician, and I was going to be a physician from the moment anyone in my family thought about it, which was approximately from the moment of my birth. I did not resist this. I want to be honest about that. I did not resist it because I wanted it, genuinely and from an early age, in a way that had nothing to do with my father's expectations and everything to do with the thing itself. I wanted to understand the body. I wanted to understand what went wrong inside it and what could be done when something went wrong. That desire has been the organizing principle of my life for 70 years, and I have not regretted it on any day that I can identify. I trained in Bristol and then in London at University College Hospital, beginning in 1860. I was 18 years old. I will tell you what the surgical wards of University College Hospital were in 1860, because I think the description is necessary before anything else I have to say will make sense. The wards were long rooms, with beds along both walls, and a smell that I will not attempt to romanticize or soften. The smell was infection and blood, and the specific odor of human tissue in various states of compromise. You stopped noticing it after several weeks, which is itself a thing worth noticing. The human capacity to normalize conditions that should not be normalized, that should remain alarming, that would remain alarming to anyone encountering them for the first time. We stopped noticing because we had to continue functioning, and the body cooperates with necessity in ways the mind does not always endorse. The surgical theater was a different room. At University College, it was a genuine theater, tiered seating for students and observers, a central table of wood that had been scrubbed so many times that the grain had opened and was impossible to fully clean, a skylight above for natural light because the procedures had to be seen and gas lighting was insufficient. The students sat in the tiers. The surgeons operated below. There was sawdust on the floor to absorb what needed to be absorbed. My first operation as an observer was an amputation of the leg below the knee. The patient was a man of perhaps 40, a laborer who had sustained a crushing injury to the foot and lower leg that had gone to gangrene in the time between the injury and his arrival at the hospital. He was brought in on a stretcher by 2 orderlies and lifted onto the table, and he was fully conscious and fully aware of what was about to happen to him, and the awareness was visible on his face in a way that I have never been able to forget and have never tried to forget because I believe it should be remembered. The surgeon was a man named Hartley, who was the finest technical surgeon I have encountered in my career. Fast, precise, economical in his movements in a way that only became fully legible to me years later when I understood what speed meant in the context of a conscious patient. Hartley spoke to the patient briefly, not at length. There was nothing at length to say. He told the man what was going to happen, and he told him it would be over quickly, and he told him to be as still as he could manage. Then 2 orderlies took hold of the man, and I was asked as a student observer to assist in the holding, which I did, and the operation began. I will not give you a complete account of what happened in the next 4 minutes. I will tell you that it lasted 4 minutes because speed was mercy. There was no other mercy available, and the surgeons of that era had developed their speed precisely because they understood this. And I will tell you that the man made sounds that I heard for weeks afterward in the particular way you hear things that have gone deeper than ordinary memory. I will tell you that when it was over and the leg was off and the vessels were tied and the flap was folded and sutured over the stump, the man was still conscious, still present, still on the table, and that he looked at the ceiling for a long moment and then closed his eyes. He survived the operation. He died of infection 9 days later, which was not unusual. The operation was the easy part in those years. The infection was where we lost them. I qualified in 1864 and went immediately to the war, not our war, but close enough. The Austro-Prussian conflict of 1866, where I worked as a civilian surgical volunteer attached to an Austrian field hospital for 3 months, and where I learned more about surgery in a shorter time than I had learned in 4 years of training. War surgery is surgery without any of the pretensions of surgery. It is bodies and damage, and the question of what can be salvaged and at what speed, and it teaches you things about both your capabilities and your limits that peacetime practice does not. I operated in those 3 months on more than 200 men. Amputations primarily. The musket ball of that era drove bone fragments through surrounding tissue in a way that left preservation rarely possible, and the choice between a rapid amputation and a prolonged attempt to save the limb was almost always a choice between a man who survived and a man who did not. We chose the amputation. We chose it quickly, and we did it quickly, and we moved to the next man. I had no anesthesia in the field hospital. I want to be precise about that. Ether had been demonstrated in Boston in 1846, and chloroform had been used in London from 1847, and by 1866 both were available and in use in properly equipped surgical settings. But a field hospital in an Austrian village in the summer of 1866 was not a properly equipped surgical setting. It was a barn with straw on the floor and trestle tables and men waiting in a yard outside in the July heat, and a supply chain that had broken down completely in the 3rd week of fighting. What we had was speed and laudanum, which is tincture of opium, which dulls the pain without eliminating it, and keeps a man in a state of reduced resistance that is not insensibility, but is better than full wakefulness. What we had was strong orderlies, and the particular psychological authority of a surgeon who speaks with complete certainty, which I had learned was a tool as real as any instrument in the case. A man will submit to a great deal if the person above him conveys, without hesitation, that what is happening is necessary and will end. I came back from Austria knowing what I was capable of and what I was asking of the men on my table, and the combination of those two kinds of knowledge changed the way I practiced for the rest of my career. The anesthesia question is what I most want to address, because I think it is misunderstood in a particular way that troubles me. Ether was demonstrated publicly by William Morton at Massachusetts General Hospital on the 16th of October, 1846. I was 4 years old. My father was practicing surgery in Bristol, using the methods I have described, holding men down, operating with maximum speed, losing a significant proportion of his patients to post-operative infection. When ether reached England and when my father first used it in 1848, he told me later, I was 6. I absorbed the story as a child absorbs things, partially and permanently. He told me that the first time he operated on a patient who was fully insensible, who did not cry out, who did not move, who lay still on the table and gave him time, he stood for a moment before making the first incision and could not immediately proceed, because nothing in 20 years of practice had prepared him for that stillness. I understood this completely when I had my own first experience of operating on an anesthetized patient, which was during my training in London in 1861, 15 years after Morton's demonstration. 15 years. By 1861, ether and chloroform were in regular use in major hospitals. But the transformation was not instantaneous, and it was not without complication, and the complications are part of the history that deserves honest account. Chloroform is a simpler agent than ether for the administrator. It requires a smaller dose to achieve insensibility, and it does not produce the prolonged excitement phase that ether sometimes caused, during which a patient could become violent and difficult to control. My father preferred chloroform from 1850 onward. I trained on chloroform. I used chloroform for the first 20 years of my career, and I have great respect for it, and I have also seen it kill people, because the therapeutic window, the margin between the dose that produces surgical anesthesia and the dose that stops the heart, is narrow in ways that were not fully understood in the early years, and deaths occurred, and the deaths were not uniformly reported or honestly attributed. I lost a patient to chloroform in 1871, a woman of 32 in good general health, requiring an operation for a tumor of the breast that was straightforward in its surgical aspects. She went under the chloroform without difficulty. She did not come back out of it. Her heart stopped on the table at a level of anesthesia that I had administered without incident in the preceding years, and the variation that killed her was a variation I could not have predicted with the knowledge I had, and the knowledge that exists now that would have allowed the prediction did not exist then. I have thought about that woman, whose name was Mrs. Harriet Colwood, on more days than I can count in the 50 years since. I have thought about whether I could have done differently, and the honest answer is that I could not have done differently with what I knew. And the honest additional answer is that not being able to have done differently does not eliminate the weight of it, and should not, and I have never asked it to. The infection question is where the true revolution of my career lay, and I want to be precise about this because I was present for it in a way that was, in retrospect, remarkable. Joseph Lister was at Glasgow when I was training in London. He was developing in those years his antiseptic method, the application of carbolic acid to wounds and instruments and the hands and clothing of the surgeon, based on the germ theory that Pasteur had been elaborating in France. The theory held that infection was caused by living organisms, microbes, introduced into wounds from the environment and from the hands and instruments of the surgeon himself. This was not the prevailing view when I trained. The prevailing view was that infection was caused by bad air, miasma, and that the surgical environment was to be managed in terms of ventilation and cleanliness in a general sense, not in terms of the specific destruction of specific organisms. Good surgeons in 1862 wore their operating coats with some pride in their accumulated staining, because the staining was evidence of experience. The coat that had absorbed years of operations was a coat that announced its owner as a man who had operated for years. No one thought about what lived in those stains. Lister published his findings in 1867. I read them in 1868. I was 26 years old, and I had been in practice for 4 years, and I had lost, in those 4 years, a proportion of my patients to post-operative infection that I had accepted as the natural order of things, because everyone around me accepted it as the natural order of things. I tried Lister's method in 1869, not because I was an early adopter by temperament. I am not by temperament an early adopter. I am by temperament a man who wants to see evidence accumulate before he commits. But because I spent 6 months watching the evidence accumulate in my own ward, comparing the outcomes of cases managed with carbolic against cases managed without it, and the evidence was not subtle. It was not a marginal difference. It was the difference between patients who healed and patients who died, stated plainly and without equivocation. I have been practicing antiseptic surgery since 1869. In the 40 years since, I have watched the infection rate in my surgical ward fall from something between 30 and 40% of operated cases to something that in a well-managed antiseptic environment is closer to 2 or 3%, from 30 or 40 in 40 years. That is the revolution, not the anesthesia, though the anesthesia was transformative and necessary, and I do not diminish it. The revolution was understanding that we were killing people with our own hands, that the surgeon, coming from the autopsy room to the delivery room to the operating table without washing, was carrying death from one patient to the next in the most literal possible sense, that the code of honor, stiff with the evidence of years of experience, was a code of killing. That knowledge, once available, was not universally welcomed. I want to be honest about this because I think it reflects something important about how people receive information that requires them to accept responsibility. There were surgeons of my generation and older who rejected Lister's findings not because the evidence was unclear, but because the implications of accepting the evidence were too large. To accept that the infection rate in your ward was partly a product of your own practice was to accept that some of the people who had died in your care had died at your hands, albeit unknowingly. Some men could not make that acceptance. I made it. I made it because the alternative was to continue killing people at a higher rate in order to protect my own comfort, and I was not willing to do that. And I am not willing even now to pretend that the decision was more complicated than that. I am 81 years old. I have been practicing medicine for 57 years, across a span that begins with men held down on a wooden table in a theater with sawdust on the floor, and ends in wards that would be unrecognizable to the surgeon I was at 22. Anesthesia, antisepsis, the germ theory fully established. The understanding of anatomy deepened by decades of careful study conducted under conditions that are no longer a confession of brutality. What I want to say at the end of this is something that does not get said often enough. The men and women on those tables before anesthesia were not simply sufferers. They were not only victims of a medicine that had not yet found its tools. They were people who submitted to the knife knowing exactly what submission meant, because they had no other option if they wanted to live, and they lay on that table and they endured it, and many of them endured it with a courage that I have not always found words adequate to honor. I have honored it in the only way available to me, which is to spend my career trying to ensure that what they endured, others do not have to endure. I do not know if that is enough. I know it is what I had to give,